Disorders of the gastrointestinal tract. Peptic ulcer. Peptic ulcer may be duodenal or gastric. Duodenal ulcers are more common and occur more often in younger adults. Gastric ulcers usually occur after middle age, and gastric ulcers should be taken seriously because they may be malignant, and peptic ulcers may lead to life-threatening complications of bleeding, perforation, and gastric outlet obstruction. The causes include Helicobacter pylori, H. pylori infection, excessive secretion of gastric acid, inadequate protection of the lining of the stomach and duodenum against digestion by acid and pepsin, and medicines like NSAIDs as non-steroidal anti-inflammatory drugs, and also corticosteroids. The symptoms include episodic abdominal pain, usually aggravated by dietary indiscretions and lifestyle. May be a minor discomfort, gnawing, burning, dull ache, or very severe pain. Typically, pain is in the epigastrum or right hypochondrium, occasionally high up behind the sternum or low down around the umbilicus. In duodenal ulcer, pain typically comes on when the patient is hungry and may wake the patient up in the middle of the night. In gastric ulcer, it is typically worsened by food and may be relieved by vomiting. It is relieved by alkalines and food in duodenal ulcer. Vomiting may occur in both duodenal and gastric ulcers, and is usually a complication in duodenal ulcer as in gastric outlet obstruction, but may be self-induced in gastric ulcer to relieve pain. So in children, the pain may be peri-umbilical. The signs elicited include weight loss, usually in gastric ulcer, and weight gain, sometimes in duodenal ulcer, and also tenderness as epigastrum, right hypochondrium, or umbilical regions. And there may be no abdominal signs too. Investigations include H. pylori, stool antigen test, hemoglobin, and esophagogastroduodenoscopy, that's endoscopy, or barium meal in the absence of endoscopy. Also, stool examination to exclude intestinal parasites. So, treatment. The treatment objectives to relieve pain as dyspepsia and reduce gastric acid secretion, to eradicate H. pylori if present, to promote healing of the ulcer, to prevent recurrence of the ulcer, also to prevent and manage complications. Non-pharmacological treatments include avoiding alcohol and tobacco intake, avoid foods that aggravate the pain, allay anxiety and stress. Surgical treatment for chronic cases with severe periodic attacks, or failed medical treatment and complications, for example perforation, gastric outlet obstruction, and hemorrhage. Pharmacological treatment for dyspepsia, the first line treatment, you give magnesium trisilicate oral 15 milliliters 8 hourly in between meals and at bedtime to control dyspepsia, or aluminium hydroxide oral at 500 milligrams 6 hourly in between meals and at bedtime. So avoid taking antacids within 2 hours of proton pump inhibitor, for example omeprazole, or esomeprazole or pantoprazole. Okay, so second line treatment, you give omeprazole oral in adults 20 milligrams daily for 4 weeks. Repeat course if the ulcer is not fully healed. For NSAID, that's non-steroidal anti-inflammatory drugs associated duodenal gastric ulcer, and gastroduodenal erosions. You can give esomeprazole oral as 20 milligrams daily for 4 weeks, and you repeat course if ulcer is not fully healed. Or you could give omeprazole 20 milligrams daily for 4 weeks, or pantoprazole oral 20 to 40 milligrams daily for 4 weeks, and repeat course if the ulcer is not fully healed. For bleeding peptic ulcer, which may be an indication for surgery, you give esomeprazole IV for adults 40 milligrams daily, or omeprazole IV 40 milligrams 12 hourly for up to 5 days. Okay. For Helicobacter pylori eradication, triple therapy is usually recommended. So majority of the patients presenting with duodenal ulcer are infected with H. pylori, and eradication of H. pylori should be done using a 10 to 14 course of treatment consisting of a PPI, it could be omeprazole, esomeprazole, pantoprazole, plus a combination of 2 antibiotics like amoxicillin, clarithromycin, or metronidazole. So the first combination, esomeprazole oral, you give 20 milligrams 12 hourly plus amoxicillin oral 1 gram 12 hourly plus clarithromycin oral 500 milligrams 12 hourly. Or you could give esomeprazole oral 20 milligrams 12 hourly plus clarithromycin 500 milligrams 12 hourly plus metronidazole oral 400 milligrams 12 hourly. Or you could give omeprazole oral 12 milligrams 20 milligrams 12 hourly plus amoxicillin 1 gram 12 hourly plus clarithromycin 500 milligrams 12 hourly. Or you could give omeprazole oral 20 milligrams 12 hourly plus amoxicillin oral 500 milligrams 8 hourly plus metronidazole oral 400 milligrams 8 hourly. Or you could give omeprazole oral 20 milligrams 12 hourly plus clarithromycin oral 500 milligrams 12 hourly plus metronidazole oral 400 milligrams 12 hourly. You could also give pantoprazole oral as a PPI as 40 milligrams 12 hourly plus 1 gram amoxicillin oral 12 hourly plus clarithromycin 500 milligrams 12 hourly. Or you could give pantoprazole oral 40 milligrams 12 hourly plus clarithromycin oral 500 milligrams 12 hourly plus metronidazole oral 400 milligrams 12 hourly. But avoid treatment regimens including amoxicillin in patients with penicillin allergy. Referral criteria: refer for specialist care when there is failure of H. pylori eradication or if surgery is indicated.